morning, everyone. Dear seniors, colleagues, and my dear students. At the outset, I would like to thank KSOs and Dr. Rajesh sir for giving this opportunity. And I also sincerely thank my colleagues and friends for helping me out make this presentation. So this talk is on tonometers. We'll discuss about applanation tonometer and briefly about shear tonometer and non-contact tonometer. So intraocular pressure is the pressure exerted by the intraocular contents on the cords of the eyeball, and it is maintained by the equilibrium between the aqueous production, the outflow, and the episcleral venous pressure. The normal range is from 10 to 21 millimeters of mercury, and it is important because it is the only modifiable risk factor in glaucoma. Now, the gold standard for measuring intraocular pressure is the Goldman applanation tonometer because of its high accuracy and reproducibility. And it is based on the Imbert's-Fick's law, which states that the pressure inside a perfect sphere is equal to the force required to applanate a unit area. Now, since our cornea is not a perfect sphere and there are various other forces acting, we have modified this law and it is like this. Now, so these are the other forces acting, that is the surface tension and the bending force required to bend the cornea. When the internal area of applanation A1 becomes equal to 7.35 millimeters square, these two forces will balance each other. And this is obtained when a 3.06 millimeter diameter area on the external corneal surface is applanated using a biprism. So this is the principle of your Goldman applanation tonometer. Now, it has got 6 parts. The first part, which connects to the slit lamp, the measuring biprism. You have you have markings from 0 to 180 degree, and the holder has a white mark and a red line. The red line is at 43 degrees to the white line. The feeler arm, the control weight insert, which is required for calibrating the prism, the housing, and the revolving knob with a measuring drum, which has values from 0 to 80. So you can record from 0 to a maximum of 80 millimeters of mercury. Now, calibrating the instrument, it should be done once in a month. We have a small video here. So this scale has got readings 0, 2, and 6, which corresponds to the 0, 20, and 60 millimeters of mercury. Now, place the reading at the appropriate marking. So first keep it at 0, insert it into the control weight insert, keep the drum at 0. And when you rotate the drum slightly forward, you can see a forward movement of the feeler arm and the biprism. And when you rotate it backward, you can see a backward movement. Same, repeat at 20 and 60 millimeters. I think you saw the forward twin and the backward movement. So if this free movement is obtained, that means that your instrument is well calibrated. Now, there are certain contraindications to your procedure. That is, an applanation tonometry is contraindicated if there is active infection, if there is recurrent corneal erosions, in non-healed corneal aberrations, and open globe injuries. Now, come to the settings. So, what are the settings? You put the slit lamp at minimum magnification, maximum illumination of the slit lamp, switch on the cobalt blue filter and put the maximum height of the beam and maximum width of the beam. Keep this tonometer in the slot. The slit beam is kept at 60 degrees to the illumination to the viewing axis. Now the drum is kept at the value 1, which is equal to 10 millimeters of mercury, because it is always accurate when you move from a lower reading to a higher reading. And make sure that your white line, your white mark aligns with the 0 of the biprism. Now, with this, you after explaining the procedure to the patient, you put the anesthetic drops, stain with fluorescein, the lower conjunctival sac, preferably a fluorescent strip. Ask the patient to keep the chin on the chin rest, look straight. See that the lateral mark aligns with the eye level. Now, move the biprism gently forward, seeing through the side. Don't touch the eyelashes. And as soon as you get a gentle touch on the cornea, you inspect through the left eyepiece of your slit lamp. Now, So this is how you see. This is your biprism. You can see two prisms. When you increase the illumination to the maximum, you can see two blue mirrors, semicircles. And this is the biprism applanating the cornea. You can see a rim of or a circle of tear meniscus, which when illuminated in cobalt blue light, you get a yellow ring. Now, what does this biprism do? The biprism will split this circle into two semicircles by inducing a horizontal shift. Now, when you gently touch the cornea, initially you get a fluorescent dot like this. And when you applanate further, and when the area of contact becomes equal to 3.06 millimeters, you can see that the two semicircles will become interlocked. So, when do you say that your tonometer is in correct position? When you get two regular pulsating semicircles of same size with well-defined margins, and these pulsations correspond to the cardiac cycle. Now, what would you do? You should rotate the drum forward, and you get the end point when the internal edges of the semicircles meet at the midpoint of these pulsations. So that is the end point of your procedure. Now take the reading on the drum, multiply it by 10, and it gives the intraocular pressure in millimeters of mercury, and which you usually record it as like this, and also you record the time of recording also. You have a small video here. I think you can see the two semicircular mirrors. They are moving regularly corresponding to the cardiac pulsation, and at this point you have to rotate the drum forward, get the marking so that the internal edges of these two mirrors meet at the midpoint of this pulsation. Now take the reading, multiply it by 10, gives the pressure. Now suppose you are getting something like this. This is an inaccurate horizontal alignment. This means that the IOP is still higher. You have to rotate the knob in the clockwise direction to get the correct endpoint. Now, the lower picture shows that you are applanating more. So you have to rotate your drum in the anti-clockwise direction. Now, this is inaccurate vertical alignment. You have a bigger circle above. So that means the probe contact is too inferior. So move the probe superiorly. The lower picture shows that the probe contact is more superior. Move the probe inferiorly. So the dictum is move the probe towards the larger semicircle. Now, sometimes you may get thick mirrors like this. So they can produce an overestimation of intraocular pressure. So you should wipe the tip as well as the eye. Sometimes it could be like very thin mirrors as shown here. You have to reinstall fluorescein and redo the procedure. Now, this is a problem that is in astigmatic corneas, you may get an elliptical area of applanation. So what you should do is, if for an astigmatism of more than or equal to 3 diopters, the axis of the minor cylinder is aligned with the red line or the A marking on the prism holder. Or an easy method is take readings in vertical and horizontal directions and take the average of both values. Now, this is a problem that you can face in your early periods. You may go for a prolonged contact with the cornea, and that can produce probe toe marks as shown in the picture. And the lower picture shows an inappropriate contact. This means that the instrument is moved too much further towards the patient. Now, the mirrors will not move by changing the drum. So what should you do? You move backward and re-applanate. Now, there are certain corrections and limitations. Your applanation, Goldman applanation tonometer is based for, or the calculations are based for a corneal thickness of 520 microns. Thin corneas, you get underestimation of IOP. In thick corneas, there can be overestimation of IOP. So for every 10 microns increase in thickness, reduce the value by 0.7 millimeters of mercury and vice versa. But if the corneal edema is due to pseudophakic bullous keratopathy, you get a falsely low intraocular pressure. And the applanation tonometer also has limited values in irregular corneas, as well as it cannot do over contact lenses. Now, so in the period of COVID, this disinfection is very important. So how do you disinfect? Remove the prism from the holder. A thorough cleaning under the running tap water to remove the fluorescein and lacrimal fluid has to be done prior to starting the procedure. The disinfectants that you can use are home bleach or 3% hydrogen peroxide, sodium hypochlorite or 70% isopropyl alcohol. And in between procedures, you can wipe with 3% hydrogen peroxide or 70% isopropyl alcohol. And always make sure that wipe the tip dry after cleaning with the disinfectant. And this article in KJO by Sudha Madam is helpful. I think it's everybody should go through this article. Now I'm going to the Sheart's intonation tonometer. So the Sheart's tonometer, we are all familiar with it. Now the problem is that it does not make precise measurements, but it is inexpensive and it is simple to use. So the parts of the Sheart's tonometer, that is, it has got a scale calibrated from 0 to 20, a freely deflecting needle, a lever arm, then you have a straight vertical plunger, which has an inbuilt 5.5 gram weight inside, a holder, the barrel, the foot plate, and this is the test block. Now, when you are keeping this Sheart's tonometer vertically on the surface of the cornea, what does it do? The foot plate, the plunger will indent the cornea. And this indentation will produce a fluctuation of the needle, and the needle shows a reading on the scale which is calibrated from 0 to 20. And the value of the needle and the measuring from the scale is taken. And you have a conversion table which is provided along with your intonation tonometer. And in this case, suppose if it is 4.5, the intraocular pressure will be 18.9 millimeters of mercury. We have a small video. I've taken this from the Aravind Eye Care system. So the procedure. So this is how you hold the Sheart's tonometer, and she's checking the 0 error. See that the deflection is at 0. The patient is lying supine, anesthetized. She's fixing with her left eye onto the left thumb, and we are going to see the right eye. Gently separate the lids without exerting pressure on the globe. Gently kept on the center of the cornea. And see, you got the deflection of the needle. And it will take few seconds for the needle to stabilize. You record the value. Suppose you get a reading deflection of 3 or less, you have to add additional weight to the tonometer. Like you have 7.5 gram weight and 10 gram weight is also available. Now here we can see that she is going to add a 7.5 gram weight. So that's a 7.5 gram weight. It is added. Again, hold the instrument vertical and keep it over the center of the cornea and record the reading. And this is the procedure. And after the procedure, always instill a drop of antibiotic in the conjunctival sac. So now cleaning, this is the instrument. See, the plunger is separated here, and this is the test plate. These are the weights. You can remove the plunger. You can clean the barrel inside with this cotton brush that is provided along with the instrument. You can also clean the tip of the plunger with spirit or isopropyl alcohol. Now, let me give you a brief introduction to the non-contact tonometer also. See, the non-contact tonometer is an applanation tonometer that works on the principle of time interval. So
Dhanya, please hurry up.
Yes, ma'am. Yeah, just 2 more slides. So it has got a light emitter, a light detector, and here a jet of air which applanate the cornea. And as the cornea flattens, the reflected light increases, and it takes less time for a puff of air to flatten a soft eye than a hard eye. And the moment of applanation is the moment of maximum light detection by the optical sensor. So this is how do you check. This is very user friendly, can be used even by the optometrist. No anesthesia is required and reasonably accurate. And this is a screen from which you can read the values. And this is less advisable to use nowadays because they produce micro aerosols. Thank you and all the best.